Assalamualaikum and very good morning to everyone. Respected teachers, honorable guests, and my dear colleague, beloved intern doctor, welcome on behalf of Department of Pathology, CBMCB, me, Dr. Asumatul Noor, welcome you all to today's seminar, clinical meeting topic on the role of core needle biopsy in diagnosis of diseases with particular reference to breast pathology. Let's begin. Inviting our respected chairperson, Professor Dr. Nazma Parveen, Professor and Head, Department of Pathology. We request you to take your seat on the stage. She has been a wonderful guide and our inspiration to all of us. I would also like to request our honorable co-chairperson, Dr. Shahna Jahan, Associate Professor of Pathology, CBMCB, please come up on the stage. Her dedication and guidance have always motivated our team. It's our great privilege to welcome Professor Dr. Mirza Hamidul Haq, respected teacher and guide, who has graciously joined us today as the resource person. Sir, your presence is always a source of inspiration to all of us. Thank you, everyone. Please join me in welcoming them with a warm round of applause. Thank you.
Oh, look, Tony. Tony here meeting at the thing.
Assalamualaikum and good morning. Welcome you all in our weekly scientific seminar. Today we will discuss the role of core needle biopsy in the diagnosis of diseases. And in the month of October, the Breast Cancer Awareness Month, we special emphasis on the role of core needle biopsy on the diagnosis of breast cancer. We know core biopsy is the cornerstone in the modern diagnostic approaches. I wish it will be an enriched discussion. Our today's speaker, our sincere colleague, Associate Professor Dr. Ambia Begum. Now I request Dr. Shikha to deliver her speech. Sound.
Oh, it doesn't original the result. What is it about?
Honorable Chairperson, Honorable Co-Chairperson, Resource Person, respected teachers, all doctors, and beloved students. Assalamu alaikum. In this fine morning, on behalf of the Department of Pathology, I welcome you all in our today's clinical meeting on the role of core needle biopsy in diagnosis of diseases, particular reference to breast pathology. With the permission of Chairperson, now I am presenting my papers.
Core needle biopsy is a diagnostic procedure that uses a specially designed needle to remove a tissue sample. Core needle biopsy for lung in any site involves a doctor using a hollow needle, often guided. Guided is done by ultrasound, mammography or CT scan and rarely by MRI to remove a small linear pieces of tissue from the mass lesion of the breast, lung, lymph node, prostate and soft tissue in any site. Core biopsy is performed when a suspicious lump is found clinically or by imaging test. Collect a sample of tissue from that suspicious site or mass lesion for histopathological examination. Core biopsy is, however, a more reliable procedure and can distinguish between benign and malignant tumors and in situ and invasive cancers. The pathologist determines cancer cells are present or not, and if present, the specific type, subtype, grade, and other distinguishing features. In essence, the definitive diagnosis are done. In current clinical practice, the biomarker assay estrogen receptor, progesterone receptor, HER2 receptor, and Ki67 immunohistochemistry for all cases of breast cancer are performed routinely on core biopsy specimen. Thus, core biopsy can provide almost all the necessary details to guide both the surgeon and the oncologist in designing an appropriate therapeutic strategy for the management of patients with breast masses. If the biopsy sample is not sufficient, accurate diagnosis cannot be always made. It will need to be repeated. Methods of tissue sampling. Core biopsy needles typically range from 14 gauge to 20 gauge, with 14 gauge and 16 gauge needles being common for procedure like breast lesions. And the penetration depth is 22 mm. Core needle biopsy is widely acknowledged as the gold standard procedure for managing breast diseases. Several factors are considered in selecting the most appropriate imaging modality to guide percutaneous tissue sampling. These include the site, size and depth of the lesion, its proximity to the pleura, neurovascular structures, and performance status of the patient. Ultrasound techniques are ideal for imaging superficial lesions including breast, lymph nodes, the pleura, chest wall and the liver. Advantage of ultrasound guided core biopsy. It uses real-time visualization for precise needle placement within the lesion. Non-ionizing radiation, unlike X-ray or CT guided biopsy, ultrasound making it a safer option for patient. It is a less invasive and less costly procedure. Ultrasound guided core biopsy is widely used in clinical practice due to its convenience and radiation-free advantage. Disadvantage of ultrasound guided core biopsy: lesion visibility limitation such as microcalcification not associated with palpable mass lesion or very deep or obscure lesions. False negative result if the biopsy misses the truly abnormal part of a lesion or if the sample obtained is not representative. CT-guided offers better contrast resolution between tissues of different density. Pulmonary mediastinal lesions or deeper structures are clearly visualized and a detailed vascular anatomy is obtained with or without contrast enhancement. CT with multiplanar reconstruction provides a panoramic view of any lesion, in particular its relationship to the key structures including heart and blood vessels. In the lung, CT allows accurate targeting of small lesions and tracking of mobile lesions located close to the diaphragm also. CT scan has radiation hazards to the patient. It has limited use in sampling central parenchymal and nodal diseases because biopsy in this region associated with greater risk and complications. MRI guided core needle biopsy is performed when breast lump or lesion cannot be seen or assessed by other imaging methods like mammography or ultrasonography. The choice of core needle biopsy device is determined by a number of factors. Number one, the nature of the breast abnormality. The lesion is palpable or impalpable and presence of microcalcification. The availability of the various core biopsy instruments such as conventional or vacuum assisted, and the imaging modalities ultrasound, CT scan, mammography or MRI. We usually use conventional cutting core biopsy needle, which is 14 to 20 gauge spring-loaded device that fires a cutting needle into the lump or lesion. Multiple insertions are needed for sampling the target. At least 4 to 5 cores are obtained from the palpable mass. Vacuum-assisted core biopsy uses 8 to 11 gauge needles and add a vacuum system to draw tissue into the cutting chamber to facilitate larger specimen with just one shot and permit collections multiple and site and contiguous samples with a single needle insertion. Vacuum-assisted core biopsy is increasingly utilized in practice, being useful in both diagnostic and therapeutic purposes. At many institutions, it is mainly used for microcalcification. Procedure and steps of core biopsy. At first, numb the area, making a small incision and imaging guidance. Tissue sample collection. A hollow needle is inserted to remove small pieces of breast tissue. This is usually done with a spring-loaded device. Multiple samples are collected and dressing this cutting area. Advantage of core needle biopsy is it is gold standard, providing the more informative results than the FNAC. Reduced surgery. In many cases, it provides a benign diagnosis that defers surgery, reducing unnecessary procedures. Guides treatment. It provides crucial information about the tumor's type, grade and receptor status, which informs treatment decision before surgery. High diagnostic accuracy. It has a high positive predictive value for malignancy and high negative predictive value for cancer in case of suspected or benign lesions. Disadvantage of core needle biopsy. There are generally no complications with this procedure. Patient experiences some tenderness, bruising over the needle's insertion site, mild bleeding, swelling, fever or pain, and a very small fine scar may occur. The possibility of crush artifacts that may lead to false positive results, and interpretation of the limited core biopsy samples, which can also be fragmented or distorted, leads to difficulty in making a definitive diagnosis compared with surgical excision specimens. In United States, 1 in 8 women will develop breast cancer in her lifetime. This study was carried out to assess the reliability or usefulness of core biopsy in predicting the grade and type of breast cancer and assay biomarkers for therapeutic decision. Core biopsy of breast are performed freehand and under ultrasound guidance with a 14 gauge needle, and 4 to 5 cores are obtained from palpable lesions and for screen detected lesions with a 22 mm automated core biopsy gun. All patients' clinical pathological parameters, including age, site of the breast, tumor size, histologic subtype, grade, are retrieved. For malignant lesions, determination of the hormone receptor HER2 and Ki67 status was routinely carried out on core needle biopsy specimen between 2023 and 2024. Total number of breast core biopsy in our institution and a renowned laboratory in Mymensingh is 102. Among them, carcinoma of the breast is 82.353%. Diagnosis of diseases from breast core biopsy: carcinoma of the breast 82.35%, atypical ductal hyperplasia 7.84%, proliferative breast disease without atypia 4.90%, fibroadenoma 4.90%, and inflammatory lesions 1.96%. Carcinoma of the breast. Breast cancer is the most common cancer among women and the second most common among all cancers worldwide. According to the World Health Organization's International Agency for Research on Cancer, an estimated 2.3 million new cases are diagnosed globally in each year. As distribution of the carcinoma of the breast patients, breast cancer is rarely before the younger age less than 20, but it is rapidly rising in after 30 years of age and peak at age 50 to 60 years. Presentations of breast cancer: more than half of the breast cancers are asymptomatic, which is detected by mammographic screening, and 1/3 of the patient breast cancer are present with palpable mass. Almost all are discovered by the patient. Breast cancer is slightly more common on the left side of the breast according to National Cancer Institute data than right side. But in our study, we see the right side is slightly more common than left side. And the most common area involving the breast cancer are upper and outer quadrant of the breast, which is correlate with our study also. Histologic types of breast cancer: ductal carcinoma in situ, invasive ductal carcinoma, no special type, is most commonly found cancer. Invasive lobular carcinoma, medullary carcinoma, papillary carcinoma, and mucinous carcinoma also found.
Is it from your study? Or
yes, sir. It is from my study. Pathology reporting of core needle biopsy. Core needle biopsy specimen immediately after collection placed in 10% formalin and record optimal fixation and preservation for detailed histological and antigenic markers. Paraffin block and hematoxylin eosine stain slide for routine microscopic examination. The blocks are also used for further testing immunohistochemistry fish, which requires specific slide preparation and staining techniques. Histologic features of benign breast fibroadenoma, ductal carcinoma in situ, which show central comatotype necrosis with preservation of the basement membrane. Histologic features of the invasive ductal carcinoma, no special type, invasive lobular carcinoma, invasive papillary carcinoma. Now the molecular classification of breast carcinoma, which is done by immunohistochemistry. There are main 3 types of molecular classification: luminal, HER2 positive, and triple negative. Luminal A and B, which depends hormone receptor positive, and HER2 negative. Immunohistochemistry. Nowadays, it is the mandatory routine test. It is the study of detecting protein by using specific antibodies visualized with brown chromosome. HER2 human epidermal receptor, factor 2 immunohistochemistry, Ki67 immunohistochemical stain. When HER2 positive, we go for further fluorescence in situ hybridization for see the gene amplification, HER2 gene amplification. According to the National Breast Cancer Coalition, mortality rate in 2022, 6,65,684 women died from breast cancer globally. It is in 2025, it is estimated that 42,170 women and 510 men will die of breast cancer. Every 13 minutes, a woman dies from breast cancer. The 2025 breast cancer awareness theme is "Every story is unique, every journey matters." This is Pink October Breast Awareness Month. Love yourself, be responsible, and take action in time.
স্যার ফিমেল ব্রেস্টের এরিয়াতে এটা পুরো মাসটাই ব্রেস্ট ক্যান্সার অ্যাওয়ারনেস মাস।
না না, পিঙ্ক কেন বলো? পিঙ্ক বলতে
মেয়েদের এরিয়াতে পিঙ্ক বলে,
ফর ফিমেল স্যার,
ফিমেলের জন্য
পিঙ্ক ফর ফিমেল।
Conclusion. Patients in our study who had benign breast lesions diagnosed by core needle biopsy or did not undergo unnecessary surgical procedures. In case of malignant lesions, in addition to having diagnostic significance, core needle biopsy also provides adequate tissue for the evaluation of molecular markers which have extreme therapeutic and prognostic value. As benign breast lesions are more common than malignant lesions, FNAC is the first choice. If clinically or foreign imaging findings are in favor of cancer, core needle biopsy is an accurate alternative to FNAC. Core needle biopsy are recognized as the gold standard procedure for diagnostic breast cancer. The fragmented nature or small size of the samples may cause diagnostic pitfalls, and precise radiologic histopathologic correlation is needed for optimal patient management. In era of new adjuvant treatment, core needle biopsy are the preferred sample for biomarker testing. Standard immunohistochemistry is expensive and not yet established at Mymensingh. We request the authority to become a pioneer in Mymensingh division for establishing a standard center for immunohistochemistry test. Thank you all.